Hello, my name is Maanasa Gurram. I am a current MS2 at the University of Pennsylvania Perelman School of Medicine, and today I will be talking about hydrocephalus, specifically global management and related disparities. So, to begin with a brief overview, hydrocephalus refers to the accumulation of excess cerebrospinal fluid in the ventricles of the brain, and it happens to be one of the most common pediatric neurosurgical conditions globally. And despite it being very common, and despite there being significant progress in recognition and treatment of the condition over time, we still see vast disparities in management strategies and outcome in low-income countries compared to more high-resourced countries. Um, you can see that around 6,000 children develop hydrocephalus annually during the first 2 years of life, and a significant proportion, around 50% of those cases, are congenital. So not only is hydrocephalus as a whole something very relevant globally, but specifically pediatric hydrocephalus. And almost all ventricular peritoneal shunts, which is a common treatment for hydrocephalus, fail at least once, and a lot of them also fail several times over the years. Diving into epidemiology a little bit, you can see the statistics for how many pediatric versus adult versus geriatric cases of hydrocephalus are seen. And you can see specifically in regards to congenital hydrocephalus, the incidence for congenital hydrocephalus is higher in low and middle income countries than in high income countries. Again, highlighting how pediatric hydrocephalus specifically may have differences that cause their or that are causing the disparities in these differently resourced countries. The greatest burden of disease falls on the African, Latin American, and Southeast Asian regions, and that accounts for three-quarters of the total volume of new cases. Again, of course, another thing to keep in mind is that historically we have not necessarily had complete and thorough data collection on this subject, particularly in low-resourced countries. So some of these estimates are lacking, and that is something to look forward or to look towards in future directions. An important question to ask, why is there a higher case burden in low and middle income countries? Three major reasons are outlined here. One, the higher birth rate. So more newborns gives way to more cases of congenital hydrocephalus, which, as we discussed previously, there is a higher incidence of in low-income countries. Two, greater proportion of patients with post-infectious etiology may be also leading to the higher case burden. And that could be related to differences in the likelihood of certain infections in low-income countries compared to high-income countries, as well as the management of these infections in certain countries. And then three, a higher incidence of neural tube defects in low-income countries. So treatment in low and middle income countries and high income countries, ventricular peritoneal shunting, which was discussed before, tends to be a pretty common treatment. And the premise of that is essentially shunting the CSF through tubing from the ventricles in the brain down to the peritoneum. There are also other emerging approaches that are being experimented with, including endoscopic third ventriculostomy and choroid plexus cauterization. So, endoscopic third ventriculostomy essentially refers to creating a hole or opening at the base of the third ventricle to allow for the CSF drainage into the surrounding spaces. And choroid plexus cauterization is the usage of heat to mitigate the function of the choroid plexus and potentially decrease the production of CSF by the choroid plexus. So something that I thought would be interesting to look at was to look at this shunt procedure in detail and how it's done in high income countries versus low and middle income countries and examine where disparities might be popping up throughout this procedure from the beginning to the end. So looking at the shunt procedure as a brief overview, you start with pre-op imaging and diagnosis prior to the procedure to create that initial diagnosis of hydrocephalus. You then have the cranial access and ventricular catheter placement. Then is subcutaneous tunneling. Then you have the peritoneal catheter placement. And of course, after the procedure is done, post-op monitoring and follow-up is an important step to ensure that everything is going as planned and you don't need any further interventions. So here we dive a little bit deeper into the different steps of the shunt procedure, and we can really elucidate where we might be seeing the difference in outcomes and why. So starting with pre-op imaging and diagnosis, standard practice in high-income countries, CT and MRI to confirm the hydrocephalus. However, in low-income countries, a challenge that pops up is the limitation of lack of access to CT and MRI. So a diagnosis is more often based on clinical signs, which just might lead to more variability or decreased diagnosis and recognition of hydrocephalus. Um, Next, anesthesia and patient prep. So high-income countries, you have general anesthesia, full monitoring, pre-op antibiotics. And then in low-income countries, there are often a lack of specialists in general. And of course, anesthesia specialists are included in that. And there's also a lack of just certain technology. You may have a lack of pulse ox or consistent access to antibiotics. And sterility tends to be a recurring issue in low-income countries as well, again, just due to less resources and less structuring in some of these health systems. Next, scalp incision and burr hole. High-end countries, you have it done very precisely, precision instruments, and again, sterile conditions. And as we discussed in low-income countries, sterility tends to be more of a problem, more variable, and you have limited tools. And even when you do have the tools, you may not always have the disposable tools that are used in high-income countries, but rather non-disposable or reused instruments. Moving next to the ventricular catheter insertion in high-income countries, you're able to use neuronavigation or ultrasound guidance, especially in the more difficult or challenging cases. Whereas in low-income countries, again, this technology is not always there. You may have to do it with a more freehand technique, and that has, again, increased risk of incorrect positionings, especially in more challenging cases. Next, the tunneling of the distal catheter. In high-income countries, you tend to have more smooth subcutaneous tunneling, and you're able to avoid trauma through that. And in low-income countries, again, because of, as previously discussed, limited tools, limited experience, lack of specialists, you are more likely to create trauma through this part of the procedure. And then the next peritoneal catheter placement. High-income countries, you have laparoscopic or a mini open approach, and you're able to confirm placement after the procedure. Whereas in low-income countries, it's more commonly done blind, and you don't necessarily always have laparoscopic equipment to help with this part. So again, just in every step, you can see where there's higher risks, and more opportunity for something to go wrong. Use of shunt hardware, more high quality hardware in high income countries, whereas in low income countries, again, you may have to reuse shunts in some cases, and you have differences in the type of valves that you may use, which we'll go into further um, later in the presentation. And again, just limited availability of certain components. Lastly, at the end of the procedure, closure and sterile dressing. We already talked a little bit about the differences in sterility. Um, and post-op monitoring and follow-up. Overall, more regimented post-op monitoring and follow-up in high-income countries and easier access for post-op monitoring and follow-up. In low-income countries, there's often no routine follow-up. Many children have complications and it's too late. And this can be because of a variety of reasons, whether that's expense, geographical considerations, lack of access to the health system. But due to these reasons, there's just less structured and accessible post-op monitoring and follow-up. Um, so again, that kind of gives you an overview of, in quite literally every step, where you might be seeing some of these disparities pop up and the various factors that go into that. And I thought it would be interesting to also look at some specific case vignettes to exemplify how we see various social, structural, financial factors playing into the outcomes. So these are going to be two case vignettes from a Nigerian hospital. So the first one, baby X, we have an estimated 68-month-old infant found abandoned along the corridor of the neonatal unit. by patrolling security officers, and clinical history could not be ascertained because there was no caregiver or eyewitness report. And here are just some images included. You can see it's a clinical picture as well as imaging of hydrocephalus. So this child was transfused with blood, had correction of electrolytes, nutritional rehab, and empirical antibiotics was given, and the child was prepped for CSF diversion. Over a 48-hour period, there was optimization after the child was rescued, but the child still died a few days later from severe sepsis and failure to thrive. So that was the first child. Second child is a 5-year-old boy who presented on referral from a tertiary hospital on account of progressively increasing head size of 2 months, recurring seizures of 1 month, fever, and altered consciousness of 10 days. The child was on antibiotics prior to presentation and has a past medical history of arrested congenital hydrocephalus in infancy. On exam, this child had various clinical symptoms: febrile, dehydrated, macrocephalic, prominent scalp veins, etc. Had, as you can see, other signs too: positive kerning sign, global hypertonia, and hyperreflexia. So they did a brain MRI after 2 weeks, which showed signs of hydrocephalus. They did a full blood count, ventricular tap, and they diagnosed post-meningitic hydrocephalus in this case. So they gave empiric IV antibiotics. They started anticonvulsants. However, this treatment was irregular because of financial constraints. The child also had 3 negative ventricular tap CSF analysis, was scheduled for a VP shunt. The procedure was formed after 3 weeks. Again, you can see another delay here due to further financial limitations with procuring the shunt. And then on post-op day 3, the child was discharged, was seen outpatient with improved seizure control. So some insights from both these cases. Reminder, with case 1 was the child that was found after being abandoned. Here we have a late presentation from neglect and abandonment. And this case kind of gives more of an insight into social causes or stigma that might lead to some of the disparities we see. And other reported causes of late presentation include social taboos, low socioeconomic status, ignorance, misunderstanding of the early symptoms of hydrocephalus. Case 2 has to do more with structural and financial factors. You had the 2 month delay in presentation, 2 week delay in getting imaging, and then a further 2 week delay in treatment, and most of these were due to financial limitations. And to give an idea of why you might be having these financial limitations, the estimated cost for brain MRI and VP shunting procedure are approximately 80,000 naira and 200,000 naira, respectively, which is estimated to be approximately 266% and 666% of the monthly minimum wage. So here you can kind of have an idea of how disproportionate the cost is of some of these procedures to the income that families might be receiving. Just some insights into the etiologic profile of cases at this hospital. You can see most of the cases were aqueductal stenosis. You also have a couple of post-meningitis. And the recommended treatment for aqueductal stenosis is ETV. However, this procedure was not sustainable at this center because of the lack of the neuroendoscopy setup. So again, as we discussed before, simply just lack of technology, resources, and structure is a huge contributor to why we're seeing worse outcomes. The Shabra VP shunt is currently the most commonly used system at the center due to wide availability and lower cost. Generally, we talk about 2 types of shunts, the Shabra shunt and the Codman-Hakim shunt. The Shabra is a lower cost differential pressure valve shunt, whereas the Codman-Hakim is higher cost and it's a fixed pressure valve shunt. Going into, again, we talked about the differences, but going into how these might have an effect, there was a study that looked at the 1-year outcomes for shunt treatment of hydrocephalic children in Uganda. The Shabra shunt, approximately $35 was widely used in East Africa. The Codman Hakim micro precision valve shunt is around $650, more commonly used in high-income countries. And the study actually found that there was no statistically significant difference in any of the outcome categories for patients receiving one shunt versus the other. And studies like this can be very enlightening because it can tell us that there actually isn't much value to the more expensive type of shunt here, and that's not contributing to any disparities for the most part. So it makes more sense to use the more cost-effective shunt since there was no advantage found in low resource settings. So a big part of thinking about how to provide more effective care in low resource settings, especially in the context of hydrocephalus, can be these kinds of studies where it's looking at what scenarios more money, more expensive treatment, um, and more resources are contributing to better outcomes versus what scenarios the cheaper and more cost-effective treatment can be used and not have a change in outcome. So to summarize, looking at some of the major barriers that we've seen through these vignettes and just walking through the procedure, the shunt procedure, and seeing what comes up that's leading to differences in outcomes. Health system limitations are, of course, a major aspect. Access to neurosurgeons, access to ORs, OR time, follow-up, financial burdens, as we discussed, with differences in how much things may cost versus the average family income, delayed presentation and diagnosis, which can be due to lack of imaging, lack of education, lack of awareness, lack of specialists, or also social stigma. And of course, culture and geographic challenges, which also tie in the social stigma. And again, lack of access to the health system, whether that's geographic, whether that's financial, contributing to poor diagnosis and poor follow-up. Um, so I think to summarize, in the future, we definitely need more research conducted on these barriers, on all these different aspects, and on targeted interventions that can help address the roots of some of these barriers and mitigate the disparities that we have been seeing and still are currently seeing globally in hydrocephalus recognition and treatment. Thank you.